Our next speaker, it's my pleasure to introduce Dr. Tom Kovacs. He's also a longtime member of the UCLA faculty, where he's professor of medicine in the Division of Digestive Diseases. He's a key member of the Cure Hemostasis Research Group and the UCLA Center for Esophageal Disorders. Welcome, Tom.
Thank you very much. Don't get out very much, so it's always lovely to come to a place like this, and I'd like to thank the organizers for inviting me to speak about something as esoteric as foreign bodies. We can't always all agree on what foreign bodies are, but certainly I think most of us would agree that one of the most famous foreign bodies was Mr. Spock, who actually didn't live as long and prosper as long as he had hoped. I think he died about 2 weeks ago. Another illustration of a foreign body is shown here in a Canadian, actually, patient who swallowed her maple leaf thinking that it was an ice cube. You know, we do that sometimes. Unfortunately, she's no longer working at the VA. And I think all of us in the room would probably agree that this is a foreign body. I've decided not to focus very much on this area, but hopefully the organizers, perhaps next year, we can have a panel or a group discussion talking about some of these findings. Interestingly, this actually has some Canadian background as well. It's a 35-year-old gentleman that presented to an emergency department with abdominal pain and rectal bleeding, and surprisingly was inebriated. And I say surprisingly because clearly he'd misplaced his bottle of beer, but maybe he'd had one more before that. So let's go. I'd like to quickly go through some of the things and share with you some notions. It's always great to be able to talk about something like this where there's so many experts, and we all have comparable experiences with things like foreign body ingestions. And let me just run through some of this. It seems to occur quite commonly. For some reason, it always seems to be evening, nights, and weekends. I've rarely been called at noon. I don't know about any of the others in the audience. Fortunately, actually, like GI bleeding, the vast majority which stop spontaneously, most of these foreign bodies do pass spontaneously, although in subgroups, for instance, inmates where intentional ingestion is an issue, intervention rates with endoscopy may be as high as 76%, with surprisingly high surgical necessity as well. Mortality rates exceptionally low. You can see in one series of 852 adults, no deaths, one in almost 2,300 kids. So there may be morbidity, but fortunately so far, limited mortality. Typically, kids at risk, the young ones up to 6, and I'm not going to address that very much. Adults, obviously for most of us in the room, are the focus. And in that context, the vast majority have underlying issues in terms of developmental delay, psychiatric issues, or intoxication. Or a group of people where there's a secondary gain to get out of an uncomfortable circumstance to perhaps a better place, such as a medical facility. Dentures or edentulous patients are another concern. Always think that if there's one object, there might be more. In terms of the foreign body ingestion, far and away the most common is food impaction, meat, bones, whether it's fish or chicken, medication packaging, dentures. In kids, up to 3/4 of the foreign body ingestions are due to coins. And then there's other smaller things I'll show examples of: batteries, magnets, small toys, etc. Again, I think most of you are aware that the impactions will typically occur at areas of either usual angulation or anatomic narrowing, such as occurs in the esophagus, either at the UES, the arch, or the distal esophagus, sphincter areas, whether it's the pylorus or the IC valve, or obviously in areas where there's pathologic narrowing, strictures, webs, eosinophilic esophagitis, and we'll come back to that, achalasia, and the such. And also, not just proximally, but there may be mid or distal gut involvement secondary to underlying either surgery or gut malformations. And then occasionally, unfortunately, the foreign body ingestion may uncover a condition. And I don't know how well you can see. We have here an older patient with, it's too far away, with dentures that presented because she'd actually misplaced her dentures and they couldn't find them for days. Well, lo and behold, they did find them. Subsequent imaging did see progression through the bowel, but there was actually hang-up in the left lower quadrant over several days. And unfortunately, that led to the discovery of an obstructing rectosigmoid colon cancer, and which I think you can see here. And this is quite interesting because the dentures really were stuck at the mouth of the tumor. It's one of the few instances that I'm aware of, but perhaps some of the audience members have seen where you can actually take a bite out of an apple core. But coming back to the more usual instances of food bolus or foreign body impaction, this is the type of thing we're likely to see in the urgent outpatient setting or the emergency departments. Food bolus against the background of clearly eosinophilic esophagitis. And you can see that anywhere from a third to a half of food bolus impactions are related to underlying eosinophilic esophagitis, mainly because the abnormality can affect the entire esophagus. And here as well, you can see the anatomic breakdown of other potential predisposing locations and factors in the esophagus where you're likely to see obstructing lesions. The presentation, no surprises here. Older kids and non-impaired adults clearly can identify or be proud of their ingestion and localize the discomfort. Again, the cautionary tale, the area of discomfort doesn't really correlate most of the time with the impaction site, dysphagia, neck tenderness, adynophagia, all these things may occur, increased salivation, inability to tolerate oral secretions if there's more complete obstruction. The issue for those of us that deal with that is in young kids or adults that have underlying impairment or psychiatric illness may not be able to vocalize or tell us what's going on or what they did. And other signs, be it choking, refusal to eat, vomiting, drooling, etc., or underlying respiratory symptoms may be the only clue that there's an underlying food or foreign body obstruction. Physical exam, again, nothing new here, ABC, airway, the breathing status. We're checking to see if there's a possible findings suggestive of perforation with crepitus or downstream effects, looking for peritoneal signs or possibly small bowel obstruction. Imaging is potentially of value, but it doesn't always show an opaque finding. For instance, fish or chicken bones, wood, plastic, glass, thin metal objects may not be well visualized at all. And the one part I think to take home or to remember from this slide, and perhaps for the entire 20-25 minutes, is that this is not an indication for contrast evaluation. With impaction or obstruction, enhances the possibility of aspiration. Gastrographin is clearly toxic to the lungs, and so that should not be considered. To also make subsequent evaluation and removal of foreign bodies more difficult. So no contrast studies. The management, again, I believe is well known to most of us in the audience. It really depends on what's been ingested or what we find. Quite clearly, patients who are unable to manage their secretions need more emergent intervention. And overall, I think the guidelines have been expanded so that esophageal foreign bodies really should be removed within 24 hours, since delay may increase the complication risks, such as perforation. And certainly after 24 hours, it becomes more difficult to actually remove whatever's there. The timing, again, it's probably intuitive. It's been broken down into 3 types of things: a truly emergent endoscopy, where there's obstruction, patient's unable to handle his or her own secretions; the small disc batteries from the hearing aids, the calculators, that sort of things in the esophagus truly is an emergency, theoretically within a 2 to 4 hour period; and sharp pointed objects in the esophagus. So that's early. Unfortunately, midnight, gotta be there, gotta do it. Urgent endoscopy usually refers to things that could wait for a 12 to 24 hour period and range from foreign objects that are not sharp, food impaction without complete obstruction, objects that have gotten into the stomach or the duodenum, objects that are greater than 6 cms long and have failed to progress, or magnets within endoscopic reach, and I'll try and show you some examples of that. And then there's a more casual, leisurely, non-urgent approach, such as coins, which could be evaluated if there's usually the child or the adult is symptom-free. Objects in the stomach with a diameter greater than 2.5 cms. The recommendation these days is to go after those, although it's unclear how strong the available data is. And then the presence of disc or batteries in the stomach without signs of GI injury, those patients may be observed for up to 48 hours. If they remain beyond that time period, usually the recommendation is to try and go after them. Again, batteries that are greater than 2 cm are unlikely to pass. Once you clear the esophagus, most of the time we're in good shape, and most objects will pass from the stomach within 4 to 6 days. And therefore, once it's in the stomach, a conservative management approach is reasonable. You resume the patient's diet, monitor the stools for the object under question, and then periodically image with x-rays, and it may take up to 4 weeks to pass. So if the patient remains symptom-free, it's as simple as periodic imaging and screening the stool. I think the other critical element here is airway protection for all patients undergoing foreign body removal. Clearly, the ventilatory status and the airway is critical. We need to avoid aspiration. We need to protect, and I think that if we consider there's most of these patients are otherwise well, endotracheal intubation is the way to go. An overtube provides alternate airway protection, and I'll show you how that works. The equipment, well-known, safe, simple, flexible scopes. Occasionally larger double-channel instruments, as we use for hemostasis, may be helpful, but the larger scopes may make it more difficult to actually navigate around a foreign body in the esophagus, especially if there's underlying pathology. The devices, well known, rat tooth, alligator forceps. These days there's rat alligator forceps, there's shark tooth forceps, there's raptors. Whatever you can think of that has teeth has probably been tried. There's post-polypectomy snares, retrieval nets and baskets, and hoods and banding caps. And this is an array of forceps, retrieval forceps that have been used, as well as basket, a retrieval net, a talon, and they come in 3 and 4 talon sizes. And I don't know if anyone signed up, but I'm sure there's openings tomorrow afternoon. There'll be an opportunity to use some of these lovely devices to gouge different things and see what you can pick up and find, maybe even get to keep. Here's one example of a hood that is really not used as much these days, but historically was of interest, a latex hood that may help to protect against sharp or longer objects. The idea being it's hooked on or tied on with sutures to the end of the scope. Going down, it looks almost like a lampshade, but as you withdraw here schematically a fork or other sharp point objects, it'll invert and protect the LAS, protect the LAS from trauma. Overtubes actually may produce a better effect and offer additional advantages such as protecting the airway, bless you. it also clearly allows us to pass the instrument several times, which may be a benefit if you're doing piecemeal resection. And also, as you can see from the hood, it may protect the mucosa when removing sharp objects. They come in different sizes. Short, meaning about 25 cms for the esophagus, a longer one that's about 50 cms, so that if you have something in the stomach or the duodenum that you're bringing back into the esophagus to help protect against esophageal injury as you're withdrawing. You also have, with these overtubes, at least two different sizes, one to accommodate a standard scope, and that's with the yellow handle, and an orange-handled one that accommodates scopes up to diameters of 11.6 or 11.7. Here is the product insert from the manufacturer of this specific overtube, showing that you need to select with figure 1 the appropriate size. So match the overtube to the scope, yellow for the smaller scope, orange for the larger therapeutic scopes. You need to lubricate in figure 2 is very well. You need to assemble the overtube. It has two sections, an inner and an outer core. One needs to use both of those. Once that's well lubricated, you pass that over the endoscope, backloaded. You go ahead and do your procedure, your upper endoscopy, and once you've gotten to where you wish to be with the end of the scope, you then move the overtube together over the instrument. Once you've advanced the overtube assembly to the point where you wish to work on the foreign body, you then remove both the endoscope and the inner tube. That's shown hopefully in figure 5. And then once you've reattached the inflation cap, you then reinsert the endoscope so that you have an overtube that you can go back and forth very simply. Here is shown schematically is how it would work with a long overtube in the stomach using withdrawal of a safety pin into the tube to protect against laceration at the LES. In terms of the food bolus impaction, ways that one can deal with this are either on block removal, piecemeal approach, or more recently, I think it's become more acceptable to use this push technique that because so often there's distal esophageal pathology, it was felt that it was dangerous to use it. But there are 2 large studies that suggest that in almost 400 patients, gentle pressure, and of course it remains, one person's gentle may not be gentle enough, but gentle pressure produced no perforation in almost 400 patients and resulted in movement of the food bolus into the stomach and relief of the obstruction. Very simply, if you're unsuccessful with this, it's easy to nibble away with one of the retrieval forceps and then try pushing subsequently. Here's one example using one of these retrieval nets of en-bloc resection. And where that's unsuccessful, using one of the retrieval nets or a basket, I think this is a basket in fact, to piecemeal remove a large food bolus impaction and then withdraw that into the overtube. Additionally, when we face this kind of patient, again, food bolus against a background of clearly eosinophilic esophagitis, at least endoscopically, other issues come up. So ordinarily, I think most of us would agree that it's quite safe to dilate a distal stricture in a patient with, for instance, a Schottky ring. But I think caution is still advised if there's a prolonged impaction or you suspect, or in a patient like this, it looks like overt eosinophilic esophagitis. I think the consensus clearly is that after improving or relieving the obstruction, biopsies are appropriate, but most of us would defer dilation to another time, perhaps after empiric treatment. What about medical management? We all tend to use glucagon. The idea is that it relaxes smooth muscle, therefore it relaxes distal esophagus, might allow spontaneous passage. In fact, the only randomized trial I could find showed no improvement over placebo. Still, it's pretty safe and inert, and most people use it. There's no hard science to suggest that it's going to work. What about things like the Adolph's meat tenderizer? Again, I'm still not sure what the origins of that is. I don't know how Adolph's separates self from food bolus. So most of the time, or all the time, papain is not being used. And then once you see these patients, obviously in follow-up, repeat endoscopy, biopsy, if it wasn't done, dilation, and appropriate evaluation for underlying dysphagia, depending on the findings. What about short blunt objects? Coins are the most likely things, usually with these retrieval forceps, easy to get at, or using a retrieval net. In one study, I was happy to see that there is actually a study, a net was shown to be superior in a prospective study done by Dr. Roth. No, just kidding. It was by Doug Fagel. I just wanted to see if anyone was awake. But the net was shown to be superior in the situation of the coins. Objects, if you can, it could be advanced further into the stomach. It seems to be more space, easier to remove from the stomach, most of these objects. The one thing that is suggested, and as I had mentioned before, is that for larger objects, greater than 2.5 centimeters, removal from the stomach is recommended since the likelihood of it passing is low, although data is soft there. And then clearly, if there's been retention for longer than 3 to 4 weeks, most of us would go after that object. Long objects, subject of some interesting images, but clearly anything longer than 6 cms, toothbrushes, utensils, pens, etc., are unlikely to go beyond the duo, and they should be removed. And the major reason is they just stay there. Once you do image these objects, subsequent endoscopy shows that you can grasp them easily with a snare, a basket, and the idea there is to try and pull them straight into an overtube, for instance, and pulling everything out at once with one motion, so to avoid dropping, for instance, the pen or the toothbrush. Here is an illustration of this idea that longer objects, a bunch of spoons, different things, tend to be much slower to clear than, I don't know if you can see down below, something else, assuming that it was consumed at the same time. Unfortunately, you know, if someone's going to swallow a whole wedding registry, you're just not going to have much to do with that. So it really depends. This was removed surgically. What about sharp pointed objects? Again, relatively common. This is the chicken, the fish bones, and a whole bunch of other things that the imagination is endless. And here's one example of relatively simple removal of a chicken bone using forceps with or without an overtube. I think that clearly if there's been no progress, and this is an example of no movement out of the stomach for 3 to 5 days, and this is a child who'd swallowed a nail. This needs surgical intervention since it could not be removed endoscopically. Otherwise, retrieval forceps, nets, snares, all work very well as long as you try and orient the trailing point. And this is a time to use definitely an overtube or a hood. Here, for instance, someone swallowed their bridge. Very simple to grasp with forceps, pulling out so that the pointed edge is away or leading down below into an overtube. Out of interest, you can even withdraw, although it can be more challenging, larger bones. This is some exotic soup involving cow bone, where a woman had swallowed, as you can see from below, almost a 3 cm bone. Here the idea is if the retrieval net or the basket, the tensile strength is strong enough, one can try and screw it, as it were, into the overtube as a way to protect against trauma from the edges as you withdraw it. So there's a variety of creative ways that one can use to manage this. I wanted to just very briefly mention these disc batteries that kids especially and some of the adults go for. Very important because it can cause necrosis and perforation relatively quickly due to leakage of either sodium or potassium hydroxide. This is one of the times where you really want to protect the airway, and a retrieval net or a basket is a more appropriate approach than grasping forceps, which could puncture the lesion, yes, the battery. The other thing, I don't know if any of you all play or have buckyballs on your desk. Magnets are just an incredible lure, especially for kids, and they can be quite dangerous. I believe that actually buckyballs were pulled from the market because of this this swallowing and foreign body risk. And magnets, somewhat surprisingly, because you think that they're inert, can lead to pressure necrosis and fistula formation and perforation. And again, this is one of those things where if you see them or you see them on an imaging study or someone tells you they swallowed, we need to go after. And here's one example of magnets sitting in the distal stomach, eventually removed with a retrieval net. And you can see the rather dramatic injury from just a 4 to 6 hour exposure, thought to be due to pressure. Even if there's only one magnet, theoretically, the recommendation is to go after these if they're within endoscopic reach. Coins, most of the time they pass, usually easy with either a retrieval net or forceps to bring up. Most of the time it would be safest to use an overtube. Just wanted to show, I don't know if anyone can see quite clearly, you might need to dim the lights, but in the middle, this is one of those, someone who's caught at the airport by customs body packing. And so this is important because, again, you have to know when to say no. It can occur both in adults and children. It might be seen by an imaging study. And here the issue is that you can package surprisingly large amounts of stuff so that, for instance, for cocaine, apparently within condoms and other packages, we can get 3 to 5 grams, where 1 to 3 is considered a lethal dose. So that's one of the few times where if we think we're looking for that, we don't attempt endoscopic removal. It's a surgical issue. So in summary then, these would be the following recommendations. For patient with foreign body impaction or food bolus impaction, avoid contrast. If it's a high lesion, ENT consult, although personally I've been underwhelmed by the help from the ENT folks. Emergent removal if the foreign body is leading to complete esophageal obstruction. And esophageal and acceptable methods for food impaction include this en bloc or piecemeal removal and gentle push technique. Endoscopic removal of all objects with a diameter of greater than 2.5 cms is recommended from the stomach. If it's a long object, proximal to the duo, it's worth trying to get after it, and then remembering that emergent removal of disc batteries in the esophagus, that's truly one of the other foreign body emergencies. And then, as I mentioned, avoid endoscopic removal of drug-containing packets. And lastly, I do think it is important to know when to say when. I don't know if any of you saw this image from the New England, it's within the last month or so, of an 18-year-old autistic woman that had interesting munching habits. And in fact, showed up to an outpatient area with abdominal pain, nausea, and vomiting, and after appropriate imaging and endoscopy was found to have a huge trico bezoar. And initially they tried to deal with this through a variety of ways, including even perhaps the one indication for papain given in the form of pineapple juice. But there was no go, and after about 20 days, this patient came to laparotomy, and they found this huge trico bezoar. This is at laparotomy, incision into the stomach, removal of this bezoar, and in fact, it's got a huge cast of the stomach and most of the proximal small bowel. Again, not much we can do endoscopically. With Dr. Roth's permission, I'm going to call this Rapunzel syndrome. Thank you very much for your attention.